Assalamu alaikum, and a warm welcome to everyone joining us today on Health Hour, a program where we explore key health topics with guidance from leading medical professionals, brought to you by Dream USMLE. I'm Dr. Sabia Tasneem, your host for today's session. Today, our topic is diabetes and its management. Diabetes is one of the most common chronic health conditions in the world today, affecting nearly 500 million people worldwide. That's almost 1 in 10 adults. And the numbers are rising every year. Today, we'll explore not just what diabetes is, but practical ways to manage it and lead a healthier life. To help us understand this better, we have invited a leading expert in the field, Dr. Fariha Ishrat, an attending physician in internal medicine, who will be sharing her valuable insights on diabetes and its management. Before we dive into today's topic, I'd like to briefly introduce our Dream USMLE organization. Founded in 2015 by Dr. Abdullah Al Masood Sir, Dream USMLE is a non-profit, professional, membership-based organization dedicated to supporting Bangladeshi students and physicians aspiring to pursue medical careers in the United States. Focused on education, healthcare, and human rights, Dream USMLE serves as a vital platform for empowering individuals and addressing both national and global challenges. It is now our privilege to have Dr. Fariha Ishrat with us to guide this discussion. Dr. Fariha, thank you so much for joining us today. And could you please tell our audience a little bit about yourself?
Thank you for having me here. My name is Fariha. I graduated med school 2018 from Al Faisal University in Saudi Arabia, and then I started my residency training at Buffalo University. And I completed my residency training and then started working as an attending also still at Buffalo, but I work in South Buffalo now.
Thank you so much. So, Dr. Fariha, we're going to be diving into our topic. So, can you please first tell us what is diabetes?
So diabetes, we have different kinds of diabetes that patients can experience. All of it stems from insulin insensitivity. So your body's, your pancreas, which is an organ inside your, in the middle of your belly, it makes a hormone called insulin, which helps control your sugar spike. So right after you eat, when your sugar is high, your body should create a lot of insulin to counteract that so that your blood glucose or your blood sugar level stays normal, right? However, some people with time develop something called insulin insensitivity, which means your body is not responding to that insulin. All right. This creates what is the more common type of diabetes that patients encounter, which is type 2 diabetes. You also have type 1 diabetes, which is where someone does not make that insulin. So their pancreas are simply not creating insulin, and therefore their sugars are not being brought down by anything else. And so that is type 1 diabetes. So both of these diseases happen because someone is not creating enough insulin, whether that is because their body is not reacting to the insulin that's there, or if their body's not making the insulin at all.
Perfect. Thank you so much for explaining that so wonderfully. So, our next question is very interesting because we get this question a lot from parents with young kids. Dr. Faria, can you tell us, can children get diabetes?
The children can definitely get diabetes more often than not. When a child presents with diabetic symptoms, it's because they have type 1 diabetes, which is when their body is not making insulin. It can be something where you get it genetically. So either you got it from your ancestors, or it could simply be a disease where the child's body is attacking itself. And so it's attacking its own pancreas. And so they're not making the insulin anymore. I
Okay.
think it's more important for us then to recognize what the signs and symptoms of diabetes are, both for adults and for children, so that people know what to look out for. So, most common symptoms that patients will experience is that they're always feeling dry, so they're always drinking water and they're always peeing. So they pee more often than usual, they're drinking more water than usual, and they get more hungry than usual. And whenever you start to experience the three of these, you'd anticipate someone gains weight. However, these patients start to lose weight. So even though they're eating more, they're peeing more, they're drinking more, they're losing weight, this makes me concerned this person has diabetes. So I want to go test for it.
Yeah. So that's very interesting that you mentioned that these patients actually lose weight. Could you please elaborate more on that?
So for a lot of these patients, what's happening is their bodies are metabolizing all this food more than someone else in a in normal sugar levels. So even though they're eating more food, their bodies are just breaking it down, and they're losing weight because of it. A lot of this loss of weight is also loss of water weight, because your body is so high in sugars all the time. Your body's trying to get that sugar out of it, and so it pees out a lot of extra sugar. And as it pees out the sugar takes out more water with it. So these people are very dehydrated. Our body is mostly water. 80% of it is water. So there's a lot more water weight that you can lose losing weight than you'll lose actual mass of your body.
Wow, that's really interesting. So thank you so much, Dr. Faria, for explaining that. So next question that I want to ask you, and that is something many people wonder about as well. Can diabetes be cured completely?
So, yes, diabetes can be cured completely if you have type 2 diabetes, right? Again, like we said, there are two different kinds, or two major different kinds of diabetes, type 1 or type 2. However, if we were talking in a medical standpoint, we have smaller categories. You have something called MODI, which happens somewhere in between. You have something where patients who are diabetic and pregnant get diabetes, but that goes away with pregnancy, right? So you do have other types. So in a pregnant person that gets diabetic, yes, when the pregnancy results, they can no longer be diabetic. However, that person is at a higher risk of getting diabetes later in life than a person that never had diabetes during pregnancy. A person that has type 1 diabetes, where your pancreas aren't making insulin, the chance of that person becoming non diabetic is zero, right? That person always needs to get that insulin from outside. We do have new and improving medical therapies where we're trying to target how that happens. And so maybe down the line with stem cell therapy, we'll have a full cure for diabetes, but we don't have that yet. The second and the most common type is your type 2 diabetes, which, like I said, is your body not being sensitive to the insulin. So your body's making insulin, you're eating food, but the sugar is higher than the insulin. And so you are diabetic. In this case, what happens most often is that we can tell patients to change their lifestyle so that they can start to improve their insulin sensitivity, which mostly means increasing your muscle mass, reducing your carb intake, and increasing your fiber intake so that your body digests that sugar a little slower and your body can absorb that sugar much faster.
Perfect, thank you. That actually gives us a lot of hope because mostly we know that it's an incurable disease, but if there are ways to, avoid that, that's definitely a great news. So now
Yes.
that we have sense of what diabetes is, let's talk about why diabetes happens and who might be more at risk. You did touch about a little bit on that, but I want to ask you, Dr. Faria, why do people in general get diabetes?
So diabetes, like I said, it is an insensitivity to insulin, right? More often than not, this is a genetic problem. We can say whatever we want to, but some genetic predispositions exist all across the global south. So you'll see like Caucasian people, much less percentages of them have diabetes than people from anywhere across the global south, anywhere in Africa, anywhere in Southeast Asia, much higher populations. A lot of this results from epigenetics of the fact that our continents had famine. And so there were periods of drought or periods where our populations didn't get food. And so our bodies had adapted to low amounts of food. All right. So Bangladeshi people in the 1950s went through a famine and they didn't have enough food. So their bodies got used to not being able to to process so much food. But nowadays, since that is no longer a problem, we have this surplus of food, so our bodies can no longer tolerate the amounts of sugar and carb that we eat, right? So that's part of it. But that's the part that's out of our control. There are, however, things that are within our control. So the things that are within our control is the kind of diet that we eat now is very different from the natural kind of diet that our ancestors ate. Our ancestors ate a lot of unprocessed food that had higher amounts of fiber. Fiber, when it comes with your sugars, it attaches to them and it slowly releases them. So your body gets a slower release of sugar. Versus nowadays, we eat a lot of candy, processed food, processed bread, processed rice. All of this releases sugar instantly, and your sugar spikes, and your body isn't used to that. That's one. The second thing is that back in the day, people had much more physical labor to do. Starting from the fact that if they wanted to go somewhere, they had to walk more, or they had to ride a camel, or they had to ride a bike. All of this involved more physical activity than what we're used to. So we have become a more stagnant people. We don't move as much. We eat much more easily. And so those things pulled together have created a current problem. Obesity is a growing problem around the world because of these reasons. And as obesity increases, insulin resistance increases and diabetes increases.
Thank you so much for that wonderful expression and explaining that to us. Dr. Fariha, you mentioned about pregnancy and that it can also cause diabetes. Can you elaborate a little bit more so our audience can understand that?
Sure. So, when a pregnant woman becomes diabetic, it is often both a mixture of some genetic predisposition mixed with how her body is responding to the pregnancy. And so, just because it is often a temporary disease that patients encountering or experiencing, it does improve. So, during pregnancy, they will check your sugars and they'll check it at periodic times. If your sugars end up higher than normal, then they'll label you with pregnancy or a diabetic pregnancy or gestational diabetes, right? However, that is easy to cure, right? So we treat it, we try to keep it within control during pregnancy. Once the patient is no longer pregnant, we recheck it after they've given birth, and in most patients it recovers. However, like I said, these people have a higher predisposition of getting diabetes down the line. um how I mean, I guess, does that answer your question? Kind of.
It- yeah, it does. Thank you. The
Yeah.
reason that question was interesting, and also it's a little bit personal for me as well, because I had diabetes when I was pregnant. So I just wanted to,
Mhm.
you know, get your
Yeah.
opinion on that as well. So thank you.
Yeah. Yep.
So, next question. It is something that we all face every day in this world, which is stress. Can you please tell us, does stress actually lead to diabetes?
So stress, I think definitely can cause some problems that eventually can cause you to be higher predisposition to diabetes, right? Mostly it's because stress causes increased cortisol. Right? Cortisol is your stress hormone in the body. And because it's always high, these people are having higher surges of sugar in their blood, and your body gets used to having higher amounts of sugar in it. That in itself is a risk factor for you getting diabetic, right? The second thing is, and this is a less, like, more surreptitious way in which stress causes diabetes, is that when people are stressed, they're not making good choices with regards to food. They're not making good choices with regards to movement or physical activity. And so that's a less obvious, but a more surreptitious way in which stress can impact your risk factor of getting diabetes. But I'm not aware of any direct correlation studies that have been done to study that, but maybe you do.
Hopefully, we'll get that answer as well. Thank you. And the next question is, you mentioned about family history or genetics, right? So, someone who has a family member who is diabetic, and they're related by blood, how much should they worry? Like they're going to be getting the diabetes as well.
So it depends on who that relative is. If it is your mother, your father, you should be more concerned. A lot of the times you'll notice, like if someone's mom has it, plus their like grandma had it, or their aunts and uncles on their mom's side have it, then that tells you that on your mom's side you have a higher predisposition to diabetes. That immediately makes you a person that we're going to test more for to see your blood sugars to see if you're ever getting the diabetes. So that itself is a risk factor. And so, that in itself will mean that you will have to check your blood sugars more often and you have a higher risk.
Okay, thank you so much. And now that we understand a little bit about like what to look for, like regarding diabetes, let's move on to the next segment. So, what are the first signs? I think you already mentioned about like increased thirst, increase in frequency of urination. Is there any other symptoms that you should have a look out for?
So these are your most common signs, and we call it polyuria, polydipsia, polyphagia, right? Along with this, you can start to have other things that you notice, but these will be your most probable and most common signs.
Thank you so much. And once someone
When I say
notices,
peeing
sorry,
more
go ahead.
often,
Mhm.
sorry. When I say peeing more often, I think one way for people to really recognize this is that it wakes them up from their sleep to go pee. All right. Especially when you come to talking about children, you'll see some of these children they pee in their bed, right? So this child was doing fine, 7, 8 year old, and then now they turn like 9, and all of a sudden they're peeing in their bed, right? It's not normal for them. They became potty trained, they're not doing this. So one of the things that we'll test for in that child is, does this child have diabetes? Because the urine the urge to urinate is so much that even when you're sleeping you have to wake up to go pee, or for the child maybe they don't wake up but they end up peeing in their bed.
Right, that's a very, very interesting point because that's something a parent can easily look out for and have the child checked up earlier so that that child can get diagnosed and get the treatment.
Mhm.
So that's very interesting. Thank you. And so next we want to discuss is about how to clinically diagnose diabetes. So can you tell us the standard method by which diabetes can be tested and confirmed?
So diabetes, we like to use something called A1C, which is a blood sugar test that looks at your last 3 months of blood sugar. All right. This is how we usually follow it up. But the first diagnosis is often for most people just a blood sugar test. If you just check someone's sugar any time of the day and it's more than 200, that to me sounds an alarm bell like, oh, maybe this person's diabetic. All right. Or you do a fasting blood sugar in the morning, which is the cheapest way to test for patients. You check a fasting blood sugar in the morning, and if it is above 120, this sounds an alarm bell for me, and I'm concerned, oh, maybe this person's diabetic. Then, how do I confirm it? For most cases, it's when we do the measure that I mentioned, where you do the A1C and it looks at how much of your blood has sugar attached to it. And it gives you a measure of the last 3 months. And that will be your preferred method of diagnosing.
Perfect. And can you tell us what is the normal blood sugar?
Your normal blood sugar should be less than 100. So in most people, healthy people, it'll be less than 100 when you're fasting or more than 2 hours post meal. However, after a meal, your blood sugar could be higher and should be less than 200 still.
Right. And what should someone do if they find out that one of the readings, they see that the blood sugar has been increased more than 200?
So if you are finding blood sugars that are higher for you, I would recommend you go to your primary care provider, let them know, and then they can test you for that A1C number, which will give you
Mhm.
a measure for the last 3 months. And if it is higher than 5.6, or then we're concerned that you have pre-diabetes. And if it's higher than 6.5, we're concerned that you have diabetes.
Okay, perfect. Thank you so much for giving us that exact number. so we can have a lookout for. And I want to also ask you, like some people are scared of, getting their blood drawn. So is there any alternative method, like for example, a urine test that can be used to detect diabetes?
So you can do a urine test and it'll give you a very rough estimate of like, oh, this person is peeing your like sugar, right? And if you're peeing sugar, that gives like, oh, this person is probably diabetic and now I want to go get tested. So yes, you could always start with a urine test, but again, your preferred method of diagnosing would be an A1C.
Perfect. Thank you.
And it's also important because we use that number to follow it up to see how well controlled your diabetes is.
Right. So thank you. And I think we have the tests and the standard results that we can see to check the diabetes. And we want to know that the diet, which is often talked about when it comes to diabetes, can you elaborate a little bit on a healthy diet for not just diabetic patients, but for also healthy adults who wants to avoid getting diabetes?
Getting diabetic. That's a
Mhm.
really important concern, right? Because if diabetes is a problem of sugar, you want to make sure that you avoid sugar. However, I think it's really important that people understand that you can't avoid, because a lot of people will think, oh, I'll just stop eating all carbs. A, it's not sustainable, right? So going into like a ketosis diet is not sustainable. And B, in a diabetic patient, it can actually be quite concerning. It can lead into diabetic ketoacidosis because your body's not naturally used to going into that. And that causes a different kind of problem altogether. So we wouldn't advise people to stop eating carbs altogether, but we'd ask them to choose healthy sources of carbs. So carbs that are less processed. For example, if you're eating brown rice, if you're eating quinoa, sources that are more natural and less processed will have fiber attached to that carb. So your sugar gets released slowly as your body slowly digests that. That is healthier for you. Vegetables, especially non-starchy vegetables. So, for example, eating broccoli is a good way to again get your carb, but get something that's slowly releasing. So you're still getting the carb, you're still getting that energy that you need from the carb, but it's not going to spike your sugar as fast. Avoiding the most common thing that people tend to like do is drink their carbs. So like caffeine with sugar in it, all your like coffee drinks that you're having, all the sodas or pop that you're having, all of this has a lot of added sugar that you don't even notice. It doesn't make you full and it's causing that sugar spike for you. So you're trying to avoid those as much as possible. And then, of course, putting in more protein into your diet. Again, protein will keep you full for longer. Protein also will give you energy, but it releases more slowly than carbs. And so that is your fish, your chicken, your lean sources of protein. So trying to eat red meat as needed, but again, your fish, your chicken, your legumes, so like dal, for example, is a good source of both getting that carb and that fiber and the protein and slowly releasing it and giving yourself energy and not getting those sugar spikes.
Yeah, we got a lot of balanced food, I would say. And the next question is also regarding the diet. When we consider fruits, in generally, we think that it's a healthy choice. What's your opinion? Is it actually good for diabetic patient?
So fruits are mostly sugar, right? Again, it is natural sugar, so I understand why people feel like it's healthier as an option. However, when you're picking fruits, you have to think of which fruits are safer for your sugars. So, um, things that don't actually affect your sugar levels are berries and kind of berries, strawberries, raspberries, blueberries, all of this. It has very little sugar in it, so it's not really going to affect your blood sugar levels. When you're talking about other kinds of sugary fruits, things like mangoes, bananas, watermelon, surprisingly, very high sugar content. So you want to try to avoid those as much as possible. I understand, however, that some people have affinity towards some of this, and everything is better in moderation. So instead of starving yourself, knowing that okay, like today I want to have a mango, but I'm only going to have half, all right, or I'm going to have it with something else that's going to give me that fiber, so it slowly releases, is a better option than telling yourself I'm never going to have another mango again, right? When it comes to fruits, even things like apples, because they have higher amounts of fiber. So anything that darkens, when you put it out and it darkens, those are actually not as bad as something that, doesn't. So, like, for example, a mango does have fiber in it, but again, like I said, in moderation. So, if you were having mangoes TID, like, stop. Okay. Limit yourself. Half a mango a day, maybe, right? And then take it from there.
Perfect. Thank you so much. And I also wanted to ask you about oats, because this
Mhm.
is something that we see people, especially diabetic people, eating as a morning breakfast every day. Do you think that oats is a good alternative as a breakfast? Like, for example, we hear that eating high, as we mentioned as well, any carbs which are highly processed is bad
Yeah.
for us. What about oats?
So these are very good nutrition questions. You know, from what I know, oats do have a higher level of fiber. However, there's still a lot of carbs. I personally wouldn't eat oats in the morning. It's something like a packet, like the sachets that you have, it's usually like 100 calories and 26, 27 grams of carbs in the morning. That's a lot. Um, I would prefer to have something like chia seeds, where again, you're still getting similar amount of calories from the same amount of portion, but more of it is protein and more of it is fiber. So the carb releases slowly.
Perfect. Thank you. So let's move on to another important point when it comes to diabetes, which is exercise. So can you please briefly elaborate on exercises that a diabetic patient should be doing?
Right. So the general consensus is we ask patients to do a minimum of 150 minutes in a week. All right. So 150 minutes of physical activity, moderate intensity within a week. Moderate intensity means that when I'm doing the physical activity, I can't hold a conversation. All right. So if you're walking, you can choose to walk, right? But if you're walking, it can't be the pace of walking where I'm gulping and I'm walking at the same time. I got to be able to do that walk, but not have a conversation. That's that pace where I know that I'm at moderate intensity. All right. So you can choose to do any kind of activity, but 150 minutes in a week. So that can be like 5 days, you do 30 minutes of it, and that's enough. Okay. So that's one. That's your cardio. Okay. Moderate intensity cardio, which can be walking, running, cycling, biking, hiking, swimming, whatever it is that makes you comfortable, whatever it is you have available to yourself, right? Really important, whatever is available to you, and you can sustainably do. The next part is you do want to do resistance training. Resistance training is where you try to grow your body's muscle, try to strengthen yourself. So at least 3 days in a week, trying to do resistance training is essential. However, when people try to plan to do resistance training, they're not able to identify what exactly to do, right? And so that's when trying to get like some kind of plan off of the internet is a good idea. Again, resistance training doesn't have to be so intensive. It can be something you do with your body weight. You don't have to go to a gym and start lifting weights and become a bodybuilder, but you're just trying to make sure that you can like maintain your own muscle mass, because as we get older our muscle mass breaks down. And then also you want to make sure that if you're able to gain muscle, so that again your body breaks down and uses up that insulin that's in your like, the sugars that are in your body, so that your insulin can work better. All right. So body weight exercises that are good to do for resistance training are often like squats, um or push-ups, pull-ups. These are easy ways to start for whoever is able to do it or how much they're able to do.
Right. Thank you so much. And we are actually learning a lot from you today.
Thank you.
So, Dr. Faria, Sometimes lifestyle changes alone aren't enough, and medications become part of diabetes management. So, can you please tell us what medications are generally used for diabetes?
So we always like to start with, and again, it depends on what kind of diabetes you have, right? So if you have type 1 diabetes, which is less common, but your body's not making insulin, you will only need to take insulin, right? So in those patients, we often end up helping them get like an insulin pump, and they'll have a blood sugar monitor that measures their sugars 24 hours a day, and they get insulin through that. For someone that is type 2 diabetic, right? Yeah, the first line is actually weight loss. All right. If you're able to lose 10% of your body weight within 3 to 6 months, you will lower your A1C. So for a person that's 100 kilograms, that's 10 kilograms. For a person that is 60 kilograms, that's 6 kilograms, whatever 10% of your body weight is. Nowadays, because we have the advent of things like Ozempic and all these other GLP-1 antagonists that help people lose weight, depending on where you live and what kind of insurance plan you have available to you, they are currently recommended by the American Cardiology Association, or ACC, American Cardiology Council, I suppose. But the ACC recommends that you use GLP-1 inhibitors as first line for management. All right, so that's one. You have metformin, which we've been using for many, many years, and it's always our first line. So we start our patients on metformin, and you can slowly go up on the dose depending on what they tolerate. Some patients get nausea, some patients get a metallic taste, some patients have other problems that they experience. Most people tolerate it pretty well. If you're not doing well using these medications, then we start to implement other oral anti-diabetic medications depending on what class you're able to tolerate. So for example, you can start a patient on something that will, you can start a patient on like an SGLT2 inhibitor. Those are pretty good these days. But some patients experience side effects from them. You can start a patient on, like a glipizide or something. And again, someone might experience a difference from it. We try to avoid things like sulfonylureas just because they're like much older medicines. They have chance of getting hypoglycemia. All right. So that's kind of like pushed back these days. So these are kind of our options closer to first line. Your last line is usually insulin. And we do have criteria for when we start insulin. So if you have an A1C of 10 or above, that's when we start to implement insulin usage in patients' diabetic care. If your sugars are controlled and your A1C is less than 10, then we don't usually recommend you use insulin.
Perfect. Thank you so much. So, you already touched about the time when we gonna be introducing insulin. As you mentioned that it's gonna be an A1C above 10. What's the um, borderline? Like, for example, we do see sometimes like people started on insulin even when their A1C is not 10.
So I would not recommend that. Again, it's not guideline, right? I do know that like some people do different things. However, guideline in so again, like guidelines vary from country to country, place to place, right? However, guideline in the US is if you have an A1C of 10 or above, we start you on insulin. Below that, we don't. I have had patients who like come from Bangladesh, for example, who were started on insulin at a lower A1C. And, I've given them the option of like, oh, we can take you off of the insulin. You can see how you do for 3 months. We remeasure and we take it from there. Because the problem with insulin is both like administration, because some people find it difficult to give themselves the shot, and then also the factor of compliance because it's difficult or painful and so on. People won't take it as often. All right. So those are two important things you want to think about. Even when it comes to giving patients tablets, you want to think of what is a patient really going to take? Because if I give them meds to take 2, 3 times a day, chances are they'll skip. But if I give them a one-time medicine or I give them a tablet that has two medicines put together, higher chance that they'll end up taking it. Right. So those are some factors to think about. The third thing to think about with insulin is we have two kinds of insulin. You have the insulin that is longer acting, less chance of people getting low sugars from that. And then you have the shorter acting insulin, very high chance of people getting low sugars from that. The problems that come with having high sugar are much less than the problems that come with having low sugar. All right. The three kinds of the complications or problems that happen from having high sugar is that you can get eye problems, right? So people get visual difficulties. They can start to get corneal opacities, right? And that becomes a whole thing, and they have to get that addressed, right? So you do want to do eye examinations on diabetic patients regularly. The second thing is that they can get kidney problems. So when someone gets diabetic, diagnosed with diabetes, and then also following up with them, we measure their urine, right? We do a urine test to look at how much protein is going out in the urine, how much is their kidney being able to retain everything, and how much kidney damage are they getting. So that's something you want to follow up and measure and control in these patients, right? So that's one of the complications that happen. So you have your eye problems, you have your kidney problems, and a lot of patients experience other complications and difficulties with nerves, right? So they start to get numbness and tingling in their hands, or they start to get numbness and tingling in their feet. Some people have problems where they're not able to digest food as well fast, all right? And that is also a nerve problem because they are starting to experience nausea with small amounts of food because their nerves or of their stomach don't allow them to slowly move the food along as fast as it used to. So different kinds of nerve problems can happen. So these are your three problems that happen with very high sugar. However, these take time. Your problems with low sugar is that you drop sugar, that person can become unconscious and that person can die, right? So it's fatal. Although it is less often, when it happens, it can kill someone, and it happens in a very short period of time. And if we're trying to avoid low sugar as much as possible, is one of the reasons we try to avoid giving our patients insulin until they really need it.
Right. Thank you so much. And another related question regards to insulin. So once a patient has been starting getting insulin, is there any chance for them to go back to taking oral medications?
So yes, it is. It is possible for patients that are on insulin to go back. Sometimes we get patients that come into the hospital or come into the clinic and they have a very high blood sugar. All right. And this is their first time getting diagnosed, and their blood sugar or their A1C is up to like 11. Okay. So in this patient, I advise them, like, we'll start you on that insulin. I advise you these lifestyle changes, this is the whole like treatment plan for you. Imagine that patient loses like 20% of their body weight. Their insulin sensitivity is already gone up. All right. Secondly, imagine they're better controlling their diet. So their sugars aren't going to be as high anymore. If they make those lifestyle changes and they become a person that can now sustain their sugars without using that insulin, they can come off of it. So a lot of patients, we do like a 6 month trial, and then you can see like if this person's A1C, and I've seen it happen in some patients who are very like compliant, they stick to what we tell them to do, their A1C comes down to like an 8 or a 7. This person no longer needs to have that insulin. So after 6 months, they can come off of it. However, unfortunately, most people, just because they're not able to make those big changes, don't really end up being able to come off of it. However, I know that some people say like, "Oh, I don't want to start it because once I start it, my body will get used to it and I won't be able to come off of it." That is not factual belief. That's just an emotional feeling that they're experiencing.
Right. Thank you so much on that clarification, because it is important for us as well as diabetic patient to know that even though you are put on insulin, you can always go back. Like if you're
Mhm.
following your advices and recommendations, and if you can
Yeah,
control your blood sugar, you can go back. So that's actually a very
exactly.
good news. Yeah, even I
If you
didn't know
can,
that. Thank you.
yeah, if you can fix what is causing it and it's something
Mhm.
fixable, then for sure. Just like how, for example, pregnant patients, we put them on insulin, but as soon as they like get off the pregnancy, they no longer have the cause for their sugars, right? Because that happens from how the placenta attaches. So the placenta is out of their body, is no longer creating those insulin resistance for the patient. So now this patient can all of a sudden come off of that insulin, right? Because their body is now better adapted. And the same thing can happen to other people if they're able to make those changes. But like I said, a lot of the times, unfortunately, people don't make those changes or they get very despondent and very, they don't have a lot of hope and then they kind of don't really put in that effort anymore.
Right. Thank you. And people who are taking oral medications, can you please give us an idea about the long-term usage? Like, are those medications safe to be used for a long time?
So the thing is, everything has a side effect. Everything, right? Whatever you take, you have a problem with it. However, it's always important to look at the cost benefit analysis of something, right? So, like, yes, if I take this medicine, I could cause myself these kinds of problems. However, so for example, with something like metformin, a lot of patients experience worsening of their nerve or like nerve numbness, right? So how do we offset that? We give them vitamin B12. So anyone that's taking metformin ideally should also be on a B12 or just a vitamin B supplement, right? So that way we kind of tend to offset any problems they're experiencing. However, these patients do have a higher risk of, for example, having kidney issues if they go to the hospital and we give them like contrast or something like that, right? Their kidneys are more sensitive. So, yes, they have that risk. However, is the benefit better than the risk? And that's that analysis that we're making. It's the same kind of problem that comes with things like vaccines. Like, yes, vaccines do give you flu-like symptoms, but they prevent you from having the actual flu. Cost benefit analysis, we choose to take the vaccine. The same thing happens with diabetic medications. I think the important one for people to remember is that if you're using a glycosyluric um, anti-diabetic medication, so something that causes you to pee out sugar, all right, and that's how your body's trying to get rid of that sugar, that can give you a higher risk of getting urine infections. All right. And that is the one time where I would be like, no, okay, we're going to take you off of this, right? Because that person, if they like someone has like one urine infection, maybe you don't want to take them off. But a lot of these patients have repeated episodes of urine infection, especially in female patients after they become postmenopausal. In that woman, her risk of getting urine infection only gets worse. And also, like I said, with a diabetic patient, I'm concerned this person has a higher chance of getting a worsened infection. And so that's when I would take someone off of it for the side effect. But in most patients, we don't tend to do that. Same thing goes for, like, for example, your GLP-1 antagonists, right? Yes, it causes like nausea. And so is the nausea tolerable? If so, maybe they continue. If not, they stop it. But like, if you have something that would stop you from taking the medication, it would be like pancreatitis, which is a side effect that happens in less than 3% of the patients. However, if you end up having any symptoms of pancreatitis, that's a medicine I will never give to you again. So that's a life-threatening condition. I don't want you to experience that. Okay. So I think the takeaway point from this is that if someone is on anti-diabetic medications or otherwise, it's important for them to do regular follow-ups. So every 3 or 6 months, you follow up with your doctor and you talk to them about what you're experiencing. And so if you have any side effects that become concerning to your doctor, they know which ones to take you off of.
Right. Thank you so much. So you explained the medical causes for which diabetic medications sometimes are withheld. I want to ask you, what if, like, because diabetes, we know that it's mostly elderly who has the diabetes, right? And they also have like memory problems, dementia, and they sometimes forget to take their medications. So I wanted to ask you, if somebody misses their dosage, is it harmful or is it extremely dangerous?
Depends on what medicine you're taking. But for most of the medicines, if you're missing a dose here or two, it doesn't really do anything to you. The only thing that I would be concerned about if you were skipping doses is your insulin. If someone is on insulin and they're skipping doses, then the medicine isn't having their effect because you need to be able to take it every single day for it to do the effect that it needs to do. Everything else, even if you don't take it every day, you do get the generalized benefit. However, taking it as much as possible is definitely good. Um, Most patients that have diabetes actually start to experience it in their mid ages. So like 50s, 60s, I wouldn't call that old. Old to me is 80s and above. And so for those patients, we usually tell them like, oh, if you're forgetting your medicine, like I said, trying to stick to giving them one-time dosing medicine. That way, like they know every day at bedtime, I'm going to take that med. The second thing is giving them like a pill counter box. That way, like they can see, like, oh, today I took it, I take it. Creating a pattern around it. So, like, you always put your medicine beside your bed. So, every day you go to your bed, you look at the medicine beside your bed and you take it before you go to sleep, as opposed to like keeping it, somewhere near your dining table and it's so busy you don't really notice it. So small measures like that, even things like just making sure everyone has an alarm clock on their phone, right, to make remind them to take the medicine, are small measures that can help improve compliance. Because again, if you're not taking the medicine like more than 80% of the time, you're not really getting that benefit. So it's not really a good measure of if the medicine's working on you or not.
Right. Thank you so much. And Dr. Fariha, you already mentioned some of the complications that can occur because of diabetes, right? You mentioned about eye problems, you mentioned about like feeling and sensation in the hands. And I just wanted to ask you specifically, can diabetes cause heart problems?
So diabetes itself doesn't, I mean, I guess you have to ask yourself what kind of heart problems, right? So having higher sugars, being diabetic predisposes you to having heart conditions. All right. Which is why the recommendation is for anyone that is diabetic, um, for 10 plus years, we recommend they start statin. They need to be on a cholesterol medicine. It doesn't matter if your cholesterol is normal. It doesn't matter if your cholesterol is high. It doesn't matter if your cholesterol is low. You need to be on a diabetic medic. If you are a diabetic patient, you need to be on a cholesterol medicine. All right. It reduces your risk of heart disease or a heart attack, to be specific and precise. Why do diabetic patients have a higher risk of having heart attacks? Because their blood is stickier. All right. Why is your blood stickier? Because they have that sugar. So my blood will just move around and it doesn't really get stuck to each other and cause blood clots that cause you to have heart attacks or strokes. Our diabetic patients, their blood is stickier because of that extra sugar. And so that blood has a higher risk of getting you heart disease, getting you strokes, etc. And so for those patients, therefore, you want to make sure you do everything to try to prevent it. So heart attacks definitely more common in heart disease in diabetic patients, but other kinds of heart diseases not really.
Perfect. Thank you. And you mentioned about diabetes causing eye problems. And
Yes.
we also know that after 40, our eyesight tends to get like we start having problem with our eyesight, right? So in general, like someone who doesn't know they have diabetes, but they're starting to have like eye problems, is it concerning in your opinion?
So, your eye power, whenever it suddenly changes, yes, you should be concerned and you should go get your sugars checked, right? Because the chances that your eye power changes suddenly as you get older is low, right? You would have reading problems. Okay. So, like, as we get older, we have trouble reading. That is normal. But if you're having any trouble seeing things far away at an older age, that's already a red flag. You're worried. Why is this happening? I want to go get my sugar checked. I want to see if I have diabetes. But if you're having trouble reading, that's kind of, age related. A 60-year-old that can't read is not really concerning to me.
Thank you. And can uncontrolled diabetes lead to amputations?
Yes. So, just like how we mentioned, like the three different things that happen um, with having high sugars, your eyes, your kidneys, and then your nerves. because you can't feel your feet, well, a lot of these patients, they end up getting injuries and wounds in their legs, right? So those wounds, because you're diabetic, wounds heal more slowly. And so some of these patients end up with diabetic foot infections. Foot infections go down to the bone. If you have a bone infection, you need to cut it off. However, that happens only for patients that don't take care of their diabetes at all. However, even if you have good, well controlled diabetes, as you get more years of diabetes, so like someone that's had it for 20 years, right, they have a higher risk of having these complications just because of age and time. So you'd ask your diabetic patients to wash their feet and to look at it themselves. So even if I can't feel my feet, I can like clean and look at my feet so I can see like, oh, do I have a foot wound here? Do I have a foot wound there? If I have any wounds, I want to go get that checked with a doctor. All right. Like a wound in a 10-year-old boy, maybe he'll heal himself. I don't really worry about it. But a wound in a 60-year-old woman with diabetes, I'm more concerned. And I want to make sure that that heals and cleans itself up properly. So that person might need wound care to follow up. Because they can't feel their feet, they tend to get more wound or foot injuries. So that's why I say, like, testing the foot and cleaning the foot and actually looking at.
Perfect. Thank you. So we got an idea about how to prevent that serious complication. And the next question I wanted to ask is, can controlling blood sugar prevent this diabetes related complications alone?
Yes. So controlling your blood sugar can help, but however, like I said, the amount of time that you spend having diabetes really does play an impact. So, someone can have well controlled sugars. However, because they're diabetic, like an average A1C of 8 or below, right? However, that person is still diabetic, right? And so that person on the long run can still start to experience some problems. Problems that we end up seeing more often than not are things like trigger finger. So, like, you get like sugar in your tendons and then you get like hands that get stuck. All right. So those kinds of symptoms you can have in patients that, just because of time. Same thing goes for your kidneys. Just because you have diabetes, even if you have it relatively well controlled, with time you'll see like chronic kidney disease. But if you do have it well controlled, you would prevent something like dialysis dependence, right? So just because your kidney function is getting worse doesn't necessarily mean that it's so bad that you need any treatment for it. But like I said, with age and with time, yes, you can, even with good control of your sugars, experience some side effects. However, it will be delayed and it will be better controlled if you have, better sugars.
Perfect. Thank you so much. So now let's take a moment to see if anyone watching live on Facebook has any questions for Dr. Fariha. Everyone, please feel free to type your questions in the comments. We'd love to hear from you. So give me one moment. Let me have a look here. Right. So it looks like there aren't any questions at the moment. So we're going to be moving on. So Dr. Fariha, before we conclude, could you please share the three key points or take-home messages from discussions for our audience?
All right. So if our target audience is, for example, Bengali people, then something that I really like to tell people is I know that you'll continue to eat rice, but if you can eat a day old rice, it will lower the impact on your blood sugar, right? So instead of eating fresh, like, garam garam matar banana bhat, right? If you can like eat yesterday's rice, that will cause a lower spike in your blood sugar and that will overall control your blood sugars much better, right? So I think that's a really like useful takeaway for a lot of my Bengali patients. And the second takeaway is trying to get in movement. I know, like with the weather being so cold, it's really difficult sometimes, which is why, maybe you're not doing something intensive. But even if you're just walking, even if you're just walking inside your house, right? After every meal, if you can do like a 5, 10 minute, even 15-minute walk, that will help the sugar that you just ate have muscles that take it up so it doesn't cause that spike. All right. So trying to get in that movement as much as you can. And then the third takeaway for patients would be, follow up with your doctors every 3 to 6 months. Follow up with your doctors. Try to take those meds as much as you can. Talk about any experiences that you're having. So you feel numbness and tingling. Mention, I have problems with my vision. Mention anything that you feel. Talk it out with your doctor because it might be significant, but you won't know it. But they will know. Oh, these are the problems my patient has. These are the meds my patients are on. I'll know, right? So follow up with your doctors, look at what you're eating, get in your movement.
Thank you, Dr. Faria, for addressing all our questions and sharing such expert knowledge in a very clear and helpful way. And we are almost at the end of today's session. And I want to take a moment to sincerely thank Dr. Faria for joining us today.
Thank you.
Dr. Faria, thank you so much for taking time out of your busy schedule to be here with us today. We got to learn so many interesting and important things about diabetes from you. And I believe everyone watching today would agree with me on that as well. So before we wrap up, Dr. Fariha, could you share your thoughts on today's session and any message you'd like to leave for our viewers?
I think this is a really important topic. A lot of patients experience diabetes. I think everybody, if you don't have it, you know someone that has it. So it's important for us to educate ourselves about it and to make sure that we know how to look out for it, how to help people that have it, and what kind of lifestyle changes that we can make. Okay. Thank you so much for having me. It's been a pleasure.
Thank you so much, Dr. Fariha, for those valuable insights. Your guidance will surely help everyone make informed health choices, and we hope to have you again in our Health Hour program soon, inshallah.
Inshallah. All right. Assalamu alaikum.
Right. And before we leave today, I would like to thank Dr. Abdullah Masood sir for providing this wonderful platform to learn from experts who are not only highly knowledgeable in their fields, but also generous in sharing their experience and insights with us. And with that, we would like to end our session today. Thank you all for joining us on today's Health Hour program organized by Dream USMLE. And we look forward to seeing you in future sessions. Until then, stay healthy and take care. Thank you.